You take it every single morning. You drop it into your palm, swallow it with your breakfast, and you feel genuinely good about it. Because everything you've read, everything you've heard, everything your body seems to tell you confirms that vitamin B12 is one of the most important things a person over 60 can do for their health. And you are absolutely right, it is. B12 supports your brain, it protects your nerves, it keeps your blood healthy, it is not optional at your age, it is essential. But here is what nobody told you at the pharmacy. Here is what got skipped during that 7-minute appointment. There are 2 medications that tens of millions of seniors take every single day, medications considered completely routine, medications your doctor almost certainly has never flagged as a problem that are quietly, systematically blocking your body from absorbing the B12 you are faithfully taking every morning, not reducing it slightly, blocking it, rendering it close to useless, while you believe you are protected. And the damage that builds from B12 deficiency in adults over 60 does not announce itself. It does not arrive with chest pain or a fever or something obvious enough to send you to the emergency room. It arrives as tingling in your fingers that you blame on poor circulation, as a fog in your thinking that you accept as just getting older, as fatigue so deep that rest doesn't touch it, as balance problems that start sending you toward walls, as depression that appears from nowhere and doesn't respond to anything. By the time most people connect those symptoms to a B12 problem, the deficiency has been building for months, sometimes years, and some of the neurological damage it causes in seniors does not fully reverse. I'm Dr. Sarah Mitchell. This channel exists for one reason: to bring you the research your doctor doesn't have time to explain in 15 minutes, presented in a way that is honest, practical, and specifically designed for adults over 60. If you haven't subscribed yet, please do that right now so you never miss what we're covering. Because today's topic is one of the most important and most consistently overlooked medication interactions in all of senior health, let's get into exactly which 2 medications we're talking about, precisely how they block B12, what that deficiency is doing inside your body, and step by step what you need to do about it starting today. Before we get into the 2 medications, I need you to understand something about B12 absorption that most people, including many doctors, never fully explain, because without this foundation, the rest of what I'm about to tell you won't make complete sense. Vitamin B12 is different from almost every other nutrient your body processes. It cannot simply dissolve and absorb on its own. It requires a very specific multi-step process just to get from a pill or a piece of food into your bloodstream where it can actually do something useful. Step 1 happens in your stomach. Your stomach lining produces something called hydrochloric acid, stomach acid. That acid breaks down the proteins in food and supplements that B12 is chemically bound to, freeing it. Step 2, also in your stomach lining produces a second substance called intrinsic factor. Intrinsic factor is a specialized protein that binds to the freed B12 and discords it through your small intestine into your bloodstream. Remove step 1, the stomach acid, and B12 never gets freed from its binding proteins. It passes through your digestive system mostly intact, mostly wasted, every pill, every morning. Now here is the piece that should stop you cold. Stomach acid production already declines naturally with age. Research published in the journal Alimentary Pharmacology and Therapeutics confirmed that up to 30% of adults over 60 have significantly reduced stomach acid output, a condition called atrophic gastritis, many of them with no digestive symptoms whatsoever. So your B12 absorption is already working against a physiological headwind before any medication enters the picture. Now add medication number 1. Proton pump inhibitors. You know these by their brand names far better than their drug class. Omeprazole, sold as Prilosec; lansoprazole, sold as Prevacid; pantoprazole, sold as Protonix; esomeprazole, sold as Nexium. These are among the most prescribed medications on the planet, and for the short-term use they were designed for 2 to 8 weeks to treat an active ulcer or severe acid reflux, they are appropriate and effective. The problem is that the vast majority of seniors taking PPIs today are not taking them for 8 weeks. They have been on them for years, sometimes for a decade or longer, without any reassessment, without anyone asking whether the original reason for the prescription still exists. Here is exactly what a PPI does. It blocks the proton pumps in your stomach lining, the specific cellular machinery responsible for producing hydrochloric acid. It doesn't reduce acid, it suppresses it aggressively. That is the entire mechanism, and that same acid suppression that gives you relief from reflux is simultaneously dismantling Step 1 of the B12 absorption process we just walked through. No acid means B12 stays bound, stays locked, passes through, goes nowhere. The research on this is not subtle. A landmark study published in the Journal of the American Medical Association examined over 25,000 patients and found that long-term PPI use was associated with a 65% increased risk of vitamin B12 deficiency. 65%, not a marginal statistical signal, a 65% higher risk from a medication that millions of seniors take every single day without a second thought about what it is doing to their nutritional status overnight. And the duration matters enormously. The same research found the association was strongest in patients who had been on PPIs for 2 or more years. 2 years. How long have you been taking yours? Comment below right now and tell me, how long have you been on a Proton pump inhibitor? Prilosec, Nexium, Prevacid, Protonix, any of them? I want our community to see the real picture of what is happening out there, because this conversation almost never happens at the pharmacy counter. Now, medication number 2, and this one reaches into a completely different population of seniors, which is exactly why together these two medications affect such a staggering number of people over 60. Metformin. This is the first-line medication for type 2 diabetes, prescribed to an estimated 90 million people worldwide. It is inexpensive. It has a long safety record for blood sugar control. It is considered so reliable that many physicians prescribe it almost reflexively for any new diabetes diagnosis and for blood sugar management. That confidence is generally well-founded, but metformin has a B12 problem that has been documented in the medical literature for decades and is still not being routinely communicated to patients. Metformin interferes with B12 absorption through a completely different mechanism than PPIs. It doesn't touch stomach acid. Instead, metformin interferes with calcium-dependent membrane receptors in your intestinal lining. These receptors are what allow the intrinsic factor B12 complex, that escort protein we discussed, to actually attach to the intestinal wall and transfer into your bloodstream. Metformin disrupts that attachment. The intrinsic factor and B12 arrive at the intestinal wall. The receptor is compromised. The transfer fails. B12 passes through. A comprehensive meta-analysis published in the journal Diabetes Care reviewed 29 separate studies and concluded that metformin use is associated with a 13% to 22% reduction in circulating B12 levels, and crucially, the reduction is dose-dependent and duration-dependent. The longer you take metformin, the higher the dose, the more significant the B12 depletion becomes. A 2021 position statement from the American Diabetes Association formally acknowledged this risk and recommended that clinicians monitor B12 levels periodically in all patients on long-term metformin. Periodically, in all patients, that recommendation exists because the evidence demanding it became impossible to ignore. Now I need you to stay with me here, because what I'm about to explain is where this goes from a nutritional inconvenience to a genuine neurological emergency for many seniors. Here is what B12 deficiency actually does inside your body when it builds over months and years. Your nervous system is wrapped in a protective coating called myelin, the same material that insulates electrical wiring. Without adequate B12, your body cannot maintain that myelin sheath properly. It degrades. And when myelin degrades, nerve signals travel incorrectly, slowly, or not at all. This process is called subacute combined degeneration of the spinal cord, and it begins in the peripheral nerves of your hands and feet before progressing centrally if it goes unaddressed. The earliest symptoms, tingling, numbness, a pins and needles sensation in the fingers and toes, are almost universally attributed to something else: poor circulation, arthritis, diabetes itself. The idea that a B12 deficiency from a diabetes medication could be causing neurological symptoms in a diabetic patient is a diagnostic trap that catches thousands of seniors every year. The patient is treated for diabetic neuropathy. The actual driver, metformin-induced B12 depletion, goes unaddressed. The damage continues.
Let me tell you about Robert. He was 71 years old. He had been managing type 2 diabetes with metformin for 8 years. For the last 2 of those years, he had been dealing with worsening numbness in both feet, fatigue that his family described as profound, and what he called a slow brain difficulty finding words, losing his train of thought mid-sentence, struggling to remember conversations from the previous day. His neurologist had diagnosed peripheral neuropathy. His primary care physician had attributed the cognitive symptoms to normal aging. His metformin dose had actually been increased 6 months before his symptoms began getting noticeably worse. Nobody had checked his B12 level in over 3 years. When we ran a full panel, his serum B12 came back at 178 picograms per milliliter. The laboratory reference range marks deficiency at below 200. He was below that floor. His methylmalonic acid, a more sensitive functional marker of B12 status, was significantly elevated, confirming his cells were genuinely starved of usable B12 despite the fact that he was eating a reasonable diet. We started him on high-dose methylcobalamin supplementation under medical supervision and worked with his endocrinologist to optimize his metformin dosing strategy. Within 3 months, his foot numbness had meaningfully improved. Within 6 months, his family told me it was like watching fog lift. His word finding improved, his energy returned to something closer to what it had been years before. Robert had not been neglected. He had been seen regularly by multiple physicians. Not one of them had connected his medication to his nutritional status to his neurological symptoms. That connection, that specific chain, is exactly what this video exists to make visible. Now let me address something critical. What if you are taking both medications? What if you are on a PPI for reflux and metformin for blood sugar simultaneously? Because that combination is far more common than you might think. PPIs are frequently prescribed to people on multiple medications because metformin itself can sometimes cause gastrointestinal discomfort, and PPIs are one of the tools used to manage that discomfort. So a meaningful percentage of seniors with diabetes are on both, and their B12 absorption is being attacked from 2 entirely different angles at the same time. There is no formal name for this specific combination the way there is for the triple whammy involving NSAIDs and kidney medications, but the pharmacological reality is just as serious. If you are on both a PPI and metformin and your B12 has not been tested recently, that gap in monitoring is not acceptable and it is entirely fixable. Now here is exactly what you do, step by step, starting this week. Step 1. Identify whether you are on either medication. Check your medication list right now. If any of the following names appear: omeprazole, lansoprazole, pantoprazole, esomeprazole, rabeprazole, or metformin, you are in this conversation. This applies regardless of how long you've been taking them or how good you feel. Good is not the same as protected. Step 2. Request a B12 blood test at your very next appointment. Ask your doctor for a serum B12 level and a methylmalonic acid test. Here is why both matter. Serum B12 measures how much B12 is circulating in your blood. Methylmalonic acid tells you whether your cells are actually using that B12 properly at the functional level. It is possible to have a serum B12 in the low normal range while methylmalonic acid is elevated, indicating a functional deficiency. Your standard test would entirely miss. Write this down exactly. I am on a long-term PPI and/or metformin and I would like my serum B12 and methylmalonic acid tested. Those exact words. Every doctor will know precisely what to order. Step 3. If you are on metformin, ask your doctor about the form of B12 you are taking. Standard cyanocobalamin, the most common form in supplements and fortified foods, requires the intrinsic factor absorption pathway that metformin partially disrupts. Methylcobalamin, the active form of B12, and sublingual or injectable B12 bypass or minimize that disruption. Research consistently shows that sublingual methylcobalamin achieves meaningful blood levels even in patients with absorption impairment. Ask specifically whether your current supplement form and delivery route are appropriate given your medication. Step 4. If you are on a PPI, ask your doctor directly and specifically, do I still need this? The original indication for most long-term PPI prescriptions was a short-term condition, an ulcer, a Helicobacter pylori infection, an acute reflux episode. Many of those conditions resolved years ago. The prescription stayed. Ask whether a supervised taper with dietary and lifestyle modifications could replace the medication. Ask whether a lower dose taken only as needed rather than daily might provide adequate symptom control. This is not a conversation to skip. Years of unnecessary acid suppression accumulating into B12 deficiency is a preventable outcome. Step 5. Do not supplement aggressively without guidance. More B12 is not automatically better, particularly if you have kidney disease, and if your deficiency is already advanced enough to be causing neurological symptoms. Oral supplementation alone may not be sufficient. You may need intramuscular injections to achieve adequate tissue levels quickly. Your physician needs to be involved in deciding both the dose and the delivery route based on where your levels actually are. One critical safety note before we close: do not stop metformin or any PPI without speaking to your doctor first. Stopping metformin abruptly can cause dangerous blood sugar instability. Stopping PPIs abruptly after long-term use causes rebound acid hypersecretion, a significant increase in acid production that can be genuinely uncomfortable and potentially harmful. Any medication change here requires medical supervision and a carefully managed transition. B12 deficiency from these two medications is not rare. It is not a theoretical risk buried in a medical textbook. It is happening in millions of seniors right now, quietly, without symptoms obvious enough to connect the dots, without anyone at a pharmacy counter mentioning it, without a single appointment where the full picture was laid out clearly. You now have the full picture. Comment below with one of 3 responses so our community can see where people are. Comment PPI if you are currently on a proton pump inhibitor. Comment metformin if you are currently taking metformin for blood sugar, or comment both if you are on both medications simultaneously. I read every single comment and your responses directly shape the topics I cover next. If this kind of honest, research-backed information matters to you, subscribe to this channel. Next week I am going to walk you through 5 specific blood test numbers that your doctor reviews every year but almost never explains in full, numbers that, when you understand what they actually mean, give you a completely different picture of where your health is heading. For adults over 60, that knowledge is not optional, it is protection. I'm Dr. Sarah Mitchell. You came here today to understand something your medical appointments haven't covered. Now you do. Take that information into your next visit and use it. Your body has been waiting for exactly this conversation.